Is Dr. Shadha Al-Raesi, and I'm the Director of Non-Communicable Disease in the Ministry of Health of Oman. Welcome to the 9th COVID-19 webinar, organized by the Arab Public Health Association in collaboration with the WHO Collaborating Center, Imperial College London. I'm honored to have been invited to chair this event. This session will discuss NCDs during and beyond the COVID-19 era. Now, as many of us are experiencing, this pandemic is pushing our health systems to the limit. It is giving a new meaning to the term health system resilience. And as many NCD managers around the world are facing, we're having to rethink our interventions and strategies to ensure the continuity of care of patients, not only during this pandemic, but also after the pandemic as well. So in terms of our first session, we will include two presentations that will provide insights on the burden of NCDs, both at a regional perspective and at a global perspective. Now, I'm happy to introduce our first speaker, Dr. Asmus Hammerich, who is the Director for Non-Communicable Diseases and Mental Health in the WHO Eastern Mediterranean Regional Office based in Cairo, Egypt. Dr. Asmus has led the department since 2016, and prior to this, he had served as WR in Uzbekistan. Thank you for joining us, Dr. Hammerich, and over to you.
Thank you very much indeed, colleagues around the world. Good morning, good afternoon, good evening. It's a great privilege and pleasure to be with you tonight, and we're very, very grateful for your interest and engagement. And I have been tasked in illustrating a little bit the situation as we perceive it in the WHO Eastern Mediterranean office when it comes to the COVID-19 pandemic and non-communicable diseases. And I will then be joined, of course, by my colleague Nick Banatvala from WHO HQ in Geneva. But let me start to frame the issue a little bit from the Eastern Mediterranean side. So I'm actually using a few of the prompts and preempting a few of the details that Dr. Nick will present a little bit later. And I will then drill down a little bit to hard data that we have collected within a global NCD country capacity survey, especially for the Eastern Mediterranean region. So the COVID-19 has combined with NCDs and inequalities to form a perfect storm, as we say, of avoidable death and suffering. And for many disadvantaged communities, COVID-19 and NCDs are now experienced as a syndemic, almost co-occurring. Furthermore, the pandemic poses a particular threat in fragile and humanitarian settings. And that's why it's so critical that we discuss it in detail also in our region that unfortunately leads the world when it comes to emergencies and refugee and displaced populations. Now, there's emerging evidence that demonstrates that the number of ways in which COVID-19 and NCDs are interacting are many. There is higher susceptibility to COVID infection in NCD patients. The pandemic is delaying and interrupting diagnostic, treatment, rehab, and other services. Pandemic measures taken in response increase a certain behavioral gamut of risk factors for NCDs and so forth. So there is, a very clear and emerging link between the two, and so addressing NCDs must be an integral part of the immediate COVID-19 response. So addressing NCDs in the COVID context needs hard data. And that's why we have recommended and worked with our member states around the world and also in the 22 member states of EMRO on the following issues. Number one, to undertake those rapid assessments of essential services, including for NCDs. Two, to restore and scale up early diagnosis and care for those suffering with NCDs. Three, raise population awareness on the links between NCDs and COVID-19. And last, identify opportunities to reduce NCD risk factors at population level. Now we have, there's more to be said, and Dr. Nick will go into this a little bit later. I'm still at the early stage of my presentation. Sorry, I had a bit of a preamble here. Let me just say one more thing, and that is that in our region, more than 150 million people are living with NCDs. This, of course, includes in our definition of the WHO, heart disease, diabetes, respiratory disease, and cancer mainly. And we have more than 100 million people living with hypertension. We have more than 50 million people with diabetes and more than 1.3 million people living with cancer. So we have a lot of reason to investigate this issue more with our countries. Hence this survey, and the slide that you see now is the overview of what has been assessed through a web-based questionnaire in our countries. 19 out of the 22 EMRO countries did respond, and the 13 questions that are listed on the next slide are basically related to NCD staffing and service disruptions, response plans, funding, level of service disruption, main causes of disruption, mitigation strategies, data collection on comorbidities, and finally, suggestions for WHO technical guidance and tools, which is a little bit an internal talk, but I believe will be hopefully interesting for the audience tonight as well. So on this slide here, yeah, the questions have been outlined. I go through them one by one, starting now with the results of the survey on NCD staff reassigned or deployed to help with COVID response. And we see that in the 19 countries that have responded, that there has been a majority of countries where indeed health staff that is mainly concerned with NCDs and mental health has been reassigned or deployed to help with COVID. Next slide, please, is related to the survey findings on NCD funding reallocated to support efforts. And there has been a certain, how shall I say, disappointment perhaps in the answer, because I believe some of our, or many of our stakeholders were not entirely sure how the budget allocation higher up in the system and in other ministries perhaps has been done. So we can't say that much about it, but I think it's emerging that funds are, of course, rechanneled towards the COVID response. Next slide, please. Countries including continuing of NCD services in a COVID plan. And there we have about two-thirds, almost two-thirds of countries have done that. But to be honest, in my sort of more anecdotal observation of national COVID plans, that may be a little bit of an overestimation. So I think the fear is here that there's not enough allocation in funds in terms of efforts and human resources and money for NCDs remaining. Next, please, is about NCD services, including an essential services of the response plan. Here, there's a strong focus, rightly so, on the very common cardiovascular diseases, cancer services, diabetes services, and so forth. So it has been recognized that treating NCDs and also preventing NCDs, of course, and promoting mental health is essential, the essential part of essential services, because they're so common and people are suffering from them. But you know, we have to put those figures also into perspective, perhaps later on. Next slide, please. Percentage of country which reported that NCD activities planned were postponed. And there we have, again, a fair amount of countries between, 25 and 65% who have already postponed some key activities for NCDs because of COVID. Next, please, access to essential NCD services. There we have some shocking figures in terms of outpatient services completely closed, understandable, but still very worrying because of the COVID epidemic. And we all know that NCD suffering patients need regular outpatient appointments because they're chronically ill patients usually. And likewise, for inpatient services, we have a mixed picture there. Next, please. NCD activities disrupted. Here, basically, in all areas of NCD management, we have severe disruptions, sometimes completely disrupted, sometimes partially, mostly partially disrupted, but still for all services, including dental care, rehabilitation, palliative care, and the main disease groups, we have definitely disruption in our country services. Next, please, is the main causes of service disruption, digging a little bit deeper. And there, again, we are seeing, of course, as main causes with almost 50% quoted closure of outpatient clinics, as was mentioned earlier, and a decrease in inpatient volume due to a cancellation of services again, and a lot of other reasons that are salient. Next, please. So as a response of health services in our countries, what have been the approaches to overcome service disruption? Well, telemedicine, of course, is one, task another. Novel supply chain and dispensing approaches, I think, has been interesting and needs to be looked at in more detail with more than 40% of responders. Triaging to identify priorities, clearly so, but also redirecting patients to alternative facilities, which oftentimes, of course, is detrimental to the convenience and sometimes access. Next, please. Data on comorbidity in COVID patients. There we have that, yes, the majority, almost 80% of our countries reported that data collected on NCD related comorbidities in COVID-19 patients. There is a huge amount of comorbidity, as we all know. And that leads us to the next slide and the last, the presentation, which is then actually for us in the WHO, and I suppose many other agencies in the UN system and beyond, what we can do to
Okay, I think we may have, Dr. Asmus may have some difficulty with the connection there. Dr. Asmus, can you hear us? Dr. Asmus? Okay, so we'll wait also for Dr. Asmus to be back, but I'll introduce the next speaker and the next presentation. To give us the global perspective of what is happening to the work of the prevention and control of NCDs is Dr. Nick Banatvala, who is the head of the United Nations Interagency Taskforce on the Prevention and Control of NCDs. Nick held many senior leadership posts at the Department for International Development, and he was the head of global affairs at the Department of Health in England. Dr. Hammerich, I can see you're back now.
Yes, I'm just back. I'm very sorry. There was an interruption in line. I was almost finished. If you allow me, I'll take one more minute. Go ahead, please. Asmus. Yeah, thank you. So, I was talking about the new technical guidance and rules that are requested from countries in this circumstance. I was talking about guidelines. I can talk about, health technology assessments, guidelines on provision of medical care to patients, addressing data needs with tools on cause of death registration, impact of COVID on NCD management, NCD registry software, projection models, further modules for upcoming NCD step surveys, regional capacity assessments. And finally, on my last slide, please, you can jump the next slide and go right to the last slide. the program needs in terms of postponement and update of WHO cooperation projects, which is quite a threat, I think, to continuity of some support, but also guidance for our staff and partners in country offices when it comes to the management and the new context. And finally, also some modifications needed to the best buy interventions for NCDs, for example, for cardiovascular disease and management in primary health care. So a lot needs to be done. A lot is on the way already. I hope those were some interesting findings, and I thank you very much for your attention. Over.
Thank you, Asmus. Very interesting indeed. And it's very unfortunate that at times we feel that we are actually turning off and turning on the button. So it's alternating between communicable and NCDs. So there is, as you said, there's much work to be done. Now, I'd like to finish off introducing Dr. Nick Banatvala. Nick held many senior leadership posts at the Department for International Development, and he was the head of the global affairs at the Department of Health in England. Again, as I said, giving that global perspective of the work that is currently happening with the NCD prevention and control in the era of COVID-19. Dr. Nick, over to you.
Well, thanks very much indeed. That's very kind. It's a pleasure to be here with you today, and I'm just trying to share the screen, which I hope is now on. You have the screen in front of you. Have you got the screen?
We do, yes.
Excellent, brilliant. Okay, well, Asmus has provided us with a very good understanding of the scale and the magnitude of the problem in one of the WHO regions. And one of the things that Asmus articulated very clearly was how NCDs has combined with COVID-19 to provide this perfect storm as he described. And he went on to describe this syndemic, and you'll see there this syndemic as being a co-occurrence of the pandemic between NCDs, COVID-19, and interacting and exacerbating existing social and economic inequalities. And one of the big areas and the big problems is this issue of the crisis, the pandemic, and NCDs in fragile and humanitarian settings. So if we look at the NCD problem overall, it's by any stretch of the imagination one of the biggest problems globally, and has been for a long time, with large percentage of the population having underlying conditions, and that is increasing their vulnerability to COVID-19. And most of those long-term conditions are NCDs. We all know that NCDs are the leading cause of death, and they kill many people prematurely. 15 million or so from cardiovascular disease, diabetes, cancer, or chronic respiratory diseases. And over 85% of these premature deaths are from occur in low and middle income countries. So, emerging evidence, which again Asmus was highlighting, but let's just go through them systematically, demonstrates that COVID and NCDs are interacting in a number of ways. First, the NCDs and their risk factors are associated with higher susceptibility to COVID-19 infection and increase the risk of severe death, disease and death from COVID-19. Secondly, again, as Asmus has described very well with his data, that the pandemic is delaying or interrupting diagnostic, treatment, rehabilitation, and palliative services. We also know that the pandemic and certain measures taken in response, such as lockdowns, are for some people increasing certain behavioral risk factors. We know that pressures on health services are likely to increase in the longer term when services are restored, A, because people haven't been able to access those services, but also a possible increase in complications from those survivors. And then finally, the public and political attention given to the pandemic has in some places led to challenges in maintaining population-led preventive interventions for tobacco use, harmful use of alcohol, unhealthy diet, and physical inactivity. So I would argue that the global community has not adequately protected the world from NCDs and their risk factors over many years, despite the fact that we've got large numbers of policies, strategies, solutions, examples of which Asmus was talking about at the end, that have been available. Despite the fact that there are reports that describe the massive economic impact of NCDs, despite the fact that there are reports that articulate very clearly the significant return on the investment from preventing and controlling NCDs. So I would therefore propose that COVID-19 is a massive wake-up call in terms of action on NCDs, or rather inaction on NCDs. The action has not been fast enough, bold enough, or at sufficient scale, and provides another urgent reason for scaling up action on NCDs, both immediately and as part of building back better. And I do know that there is some conversation that's saying that actually the focus on communicable diseases may have taken the eye off the ball from, on non-communicable diseases, may have taken one's eye off the ball for communicable diseases. But I would argue it's not one or the other. And I would go a step further to say that much, not all, but much of the COVID-19 complications and deaths are being driven by non-communicable diseases. So addressing NCDs has to be an integral part of both the immediate response and building back better. And that there are significant opportunities to integrate, and there have to be ways of integrating NCD prevention and control with addressing COVID-19 and its impacts. A silo approach is clearly not going to work. So we've got to scale up evidence-based and cost-effective interventions in line with existing policies and strategies and in line with COVID-19. And this slide here just reminds us that these plans, policies, strategies are in existence. I'm not going to go through them all, but you will see them all listed there. And anyone who's familiar with the global NCD environment will be aware, particularly of the last set of cost-effective interventions, which, if implemented, would really reduce the morbidity and premature mortality from NCDs. So, what should countries do in the first instance? Here are 4 examples that build on what Asmus was saying. First of all, undertaking rapid assessments of essential services, including NCDs, in the midst and beyond COVID-19. Restoring and scaling up diagnosis and care for NCDs as soon as feasible, because one has inevitably got to prioritize to some degree during the pandemic, but as soon as feasible, starting to move back towards normal and making sure that people with NCDs are being considered in the rollout of social protection. Third, raising population awareness on the links between NCDs and COVID-19 and how those vulnerable can protect themselves. And fourthly, identifying opportunities to reduce NCD risk factors at the population level with specific attention to vulnerable communities, including those in humanitarian settings. And Asmus again articulated the importance of digital and innovative technologies, and these certainly have to be considered seriously in the way and the approach of scaling up these activities. So, in terms of maintaining essential services, WHO has developed operational guidance, and there's the link at the bottom of the page, on maintaining health services, and highlights in that guidance NCDs, nutrition and mental health. And it advises on services to be prioritized and the way that services may need to be modified to ensure safe delivery of services in prevention, screening, diagnostic services, disease management, so on and so forth, for those different NCDs, including and beyond towards chronic kidney disease and oral health conditions as well. When it comes to building back better for NCDs, that needs to start now, and it needs to recognize the fact that people living with or affected by NCDs have by and large not been in the mainstay of development thinking, and some would say that there has been a historical dismissal of this community. That means people have not been sitting on the tables where decisions have been made about development priorities or around financing, which builds on to the second point, which is that the funding for NCDs has been woefully inadequate. Of course, most of the funding for development now and for moving forward on NCDs has to come from domestic budgets. But there does need to be A, an increase in that, and B, greater catalytic efforts from official development assistance to support this. Building back better means addressing the social, economic, and commercial environment determinants of health. Fourthly, ensuring that universal health coverage is prioritized and that there are benefit packages for universal health coverages that include NCDs, and that quality primary healthcare is prioritized as being the route towards universal health coverage and the most cost-effective approach of tackling non-communicable diseases and health. And then finally, making better use of data. Partnerships are critical in driving forward action, whether it's civil society holding governments to account, whether it's working with the private sector to make sure that they are producing safe and healthier products, whether it's partnerships with the UN system or with other development partners. And action must be grounded in a rights-based and gender-based response. And I don't think we have the time to go into that in detail, but maybe we can explore during the discussion a bit more on what that would mean. So this slide here then takes us through a health system response. And I'm not going to go through each bullet in turn, but just highlight that it's around raising awareness, it's around strengthening the health system response, it's around research and development, and it's around surveillance and monitoring. And if these slides are made available afterwards, people can kind of look at them and build on them and add to them. And of course, they link in very closely with the guidance that I highlighted earlier. But of course, NCDs always has been, always will be, a multi-sectoral agenda. And so broad sectoral actions are critical and particularly important during COVID-19, which again is also a multi-sectoral agenda. So again, there are huge opportunities for synergies. So here are 4 areas: integrating NCD prevention and control measures, international COVID-19 responses and recovery plans, in line with the UN Socioeconomic Response Framework that's been published. Secondly, ensuring that those working on NCDs are represented on COVID-19 Taskforce, and that those working on COVID-19 are also represented on NCD coordination mechanism. So the third area is around using existing national, regional, and global coordination and information networks to share information on COVID-19 and NCDs, and ensuring that people living with NCDs are engaged as part of these broader agendas. So if you then, again, look at broader sectoral actions, we have together been developing a set right across the different sectors, and we'll hopefully be publishing that fairly shortly. But I've selected out of a whole range of them just 3 examples that one can think about: the area of environmental energy, the area of finance and the economy, and then labor. And so you can look at environment and energy in terms of using the COVID-19 pollution pause to strengthen work in trying to get a greener economy, a circular economy founded on a sustainable consumption and production, which of course will have a win for non-communicable diseases. Let's have a look at something in finance and economy. This is about increased investments, recognizing that NCDs like COVID-19 carry massive avoidable economic costs, and particularly advancing health taxes. And there are some examples as a way of reducing the burden on health systems, improving public health, raising revenue. And then when it comes to labor, again, expanding and scaling up, this is bullet point 2, tobacco and alcohol cessation support at the workplace. So again, it's an opportunity to be working across sectors to try and build a more sustained response in the longer term. And then, of course, the United Nations system needs to provide effective support to countries during and beyond COVID-19. And I'm not sure that title is quite right. I would probably change that to say ensuring that the United Nations system agencies provide effective support. And here are some examples. They need to make sure that they're aligned with the comprehensive response to COVID-19, and that's articulated in the footnote at the bottom there, and I won't read them all out there, but they are there. There are three crucial framework or three crucial response plans that make up this comprehensive response to COVID-19. The second thing is that agencies need to work together to support countries, to include NCDs in national COVID-19 response and recovery plans, and the UN resident coordinator and the WHO country representative and the whole team have to demonstrate leadership and action on this. It's critical that UN country teams ensure that NCDs are included in their COVID-19 response and recovery plans themselves. So this is about the government themselves, but also the UN system in terms of their plans. Let's move on to highlight the importance at the end of making sure that task force members, or I should say UN members, are working with the task force for the prevention and control of NCDs to make sure that they are scaling up their efforts through the joint initiatives that they have. And one example that I give here is the new UN Multi-Partner Trust Fund to capitalize country action on NCDs and mental health. And that this this trust fund, which is just being established at the moment, will be designed in the first instance to support countries in their NCD and mental health efforts as part of COVID-19 response and recovery. So I leave you with this final slide here with a quote from the Director General, where he says, "It's therefore not a question of whether countries can afford to implement the best buys, if you like, the cost-effective and other recommended intervention endorsed by the UN General Assembly and the World Health Assembly, but whether they can afford not to. We have all the pieces to save lives, we just have to put them into place. The question is, and it's even more relevant now during COVID-19, is will we? It's a question we must answer with decisions we make today and every day." Thanks very much.
Thank you, Nick. One of the things you had mentioned with regards to the rapid assessment, and I'm very happy that you put it just on the top of the things that the countries should really start doing. I think I should really advocate for these rapid assessments, because there was always this sense of confusion early on with the pandemic, and definitely as the burden grows with the growing numbers of infected people with COVID, it definitely helps to have a sense of direction, which these rapid assessments provide. So thank you very much, both Dr. Asmus and Dr. Nick, for those very enlightening presentations. Now, I'm humbled to be joining these two panelists, both mentors and pioneers in the area of public health in the region. I'm honored to introduce Professor Salman Rawaf, President of the Arab Public Health Association, and Professor Tawfik Khoja, Vice President of the Arab Public Health Association. Welcome both. And thank you for the invitation, and thank you for joining me in the panel.
Thank you very much indeed, Dr. Shadha. Thank you very much for the superb session. I'm grateful to my colleague Asmus and Nick for superb representation. We have a lot of questions sent in advance to us, and there are a few also decanting while we're having this discussion. I think it's NCD is always an issue which all of us concern about, in terms of the prevalence and increasing prevalence of the NCD in terms of the global burden of disease. Secondly, ability of the system to manage these cases effectively. Thirdly, the issues of continuity of care. But we have seen all that collapse in front of us with COVID. Suddenly, everything, the shutter came down, And if I reflect on a few countries which I'm working with, as well as my country here, the United Kingdom, almost all primary care, which is the heart of our system, was closed. We stopped entirely, almost 100% face-to-face consultation, at least in the first couple of months. And there were no clear direction for people with chronic diseases, the name which we use here, or long-term conditions, NCDs, there's no clear direction because preparing for epidemics and pandemics did not include the issues of maintaining essential services. And even WHO document, unfortunately, it took such a long time for that document to be issued. It was published on the 1st of June, while we were dealing with the epidemic from February. So that issue is at the heart and mind of everyone is involved with these patients on the clinical level. It's important for people who are making decisions at public health level. Before I go to Professor Khoja, there is a question which really came from many sources. You know, don't you think that the resilience health system was dented by focusing for many years on NCD at the expense of communicable diseases? So when a pandemic of this magnitude, which was never expected, and even when it started, many countries did not believe it, that they will actually involve in such scale pandemic, you know? Don't you think that looking backward, and I'm sure we will look backward in more details later on when this COVID will be away, don't you think that was a mistake, Nick?
Well, maybe I'll start off and then Asmus can come in with his own thoughts. All I can say is, gosh, I wish we had focused and could have shown that we'd really focused on NCDs, because we'd be much further ahead of the curve than we are. If you look at what's happened in the last decade, I would say that we have stalled in terms of progress. There was quite good progress in the first decade of this century, much less so. And I would argue that if we had done better, then when this pandemic came, we would not have had quite the level and the stress on the health system that we have had. So I come back to the fact that I don't think it's either or. I think that you know, a full health system has got to be able to have pandemic preparedness, but has also got to be able to respond to NCDs. And we have seen this. This I think is my kind of hypothesis. The hypothesis of many people is that this is a pandemic that's been to a large extent driven by, or the impact has been driven by non-communicable diseases. So I don't buy that argument, I'm afraid, at all. Asmus, you may buy it, but you may have different views.
Asmus? Dr. Hammerich?
It looks like Asmus has...
Shadha, what do you think, as a director of NCD in important, actually most active ministry in the region, one of the active ministries. All of them are active, but one of the active ministries, yeah.
That's very nice of you to say, Prof. I would be, Nick, I'd like to speak as a program manager in NCDs or on NCDs. Now, unfortunately, there is that sense of we're alternating between communicable diseases and NCDs. Yes, we've always focused on NCDs, but now looking at how things and the disruption of services on NCDs, you kind of think that, okay, what are we doing wrong? So if we talk about, for example, the health system itself, we always talked about the integration of management of NCDs, and very particularly at the level of primary healthcare. But then it really seems that we didn't have that integration at the level of that organizational integration. So the people at communicable diseases are really at present leading this fight with the pandemic, and us, we are trying to put ourselves and say, okay, it's just going to affect us if you ignore NCDs. So that's one part of it. And then there's the role of PHC, where we always focused on PHC with UHC and everything. And then now COVID being really a crisis at the hospital stage, you feel that there is this sense of detachment between the hospitals and PHC, and even our own healthcare workers at the primary healthcare level, who we had trained on NCDs because we really focused on NCDs for all these years, are now having to work to screen and contact trace COVID patients. So there is that sense. Just one last point also, Nick, you mentioned the whole of government approach as well. I think what is really happening at the country level as well, whole of government approach we are seeing it right now for COVID. And one of our colleagues from Malaysia in one of the webinars had mentioned it or called it as being a loud pandemic and NCDs being so silent. So that whole of government approach is there and fighting for this loud pandemic. But we don't see, we never saw this much of an engagement when it came to NCDs. So there are a few things that we really need to reflect on, and we really need to start thinking and really focus on the redesigning of the health system, whether we need to start redesigning it and start saying, okay, we can have a crisis, either a pandemic, a storm, anything else that could really affect the delivery of services of NCDs. So that's really my...
I mean, what you're saying that you managed to break the silos within the ministry, within the service provision. I mean, this is quite assuring if it really supported and documented, and we have evidence that you managed to break the silos. And we hope these silos will be break down as well at WHO, at ministries, etc. We don't want to see in the future Department for NCD and Department for CD. This is nonsense. Actually, absolutely nonsense. We need to see department focusing on services. What do you think, Asmus, before I move to Tawfik?
Thank you very much. And I endorse a lot of the statements that have been made by the colleagues. I'll come back to your last point, which is very, very important. For me, it's really about building back better in new times and on new territory. And I think, in all fairness, if we compare this outbreak with SARS and with bird flu and swine flu, then it is a different ball game, and it does require new thinking exactly along the proposals that were made during this webinar. So it is not one or the other. We all know that especially global health initiatives have significantly scaled up efforts in communicable disease control over the last 25 years at least, Global Fund, Gavi, and so forth. And NCDs and mental health efforts have come in a little bit later and remain underfunded in relative terms. So there's certainly no funding issue, I would say. When it comes to the way forward and what works, I fully agree. It is about finding the right platforms, such as primary healthcare, more than ever, as is illustrated so well in Oman and many other countries. It is about integrating essential services. And I think we are, we're doing that, and we're doing it in countries, in governments and ministries of health, but we're also doing it in WHO. You know, myself and my team, we have been, so to speak, reassigned to the IMST for COVID, the integrated task force under the regional director for the last 6 months almost. So we have all contributed through one door, so to speak, to the outbreak in our region, and we will continue to do so. And on Prof. Salman's last point in terms of the need for separate departments or not, that's an old discussion, and I'd be interested to hear also what Dr. Shadha has to add from the Ministry of Health side, because one of the reasons I believe we still have programmatic support in WHO is the fact that that's what the governments want and need, and have encouraged us to keep. When it comes to names, as you have seen probably from my first slide, my department is now called Universal Health Coverage / NCDs, which is already a hint that we're very much thinking in an integrated way, not only on health promotion issues, but also on service delivery. I think I stop here. Thank you.
I mean, this is very good point. I'll come and revisit because there are a lot of questions related to this. Tawfik, any issues from your side?
Thank you so much, Prof. Salman, Dr. Shadha, and the rest of our eminent speaker. I enjoy it, and the level of your presentation is almost like a ministerial level. I would like to move to a level of the primary health care and the level of service delivery. I have 4 questions. I will start with the 2. The first one, as you know, that our healthcare system in the region, most of the country is built on hospital approaches. And when the hospital was only directed their activities to the COVID-19, so they stopped in the hospital, the outpatient, the inpatient, and everything was collapsed regarding the NCDs and others, and operations, and orthopedics, and so on and so forth. So it is time now to highlight on the importance of primary health care and family practice. And I know from your CV, Dr. Asmus, you are a family practice person. So I would like you to highlight, we need to send a message to the decision maker during COVID-19 and after. We have to enhance the primary health care because this is the only entrance to the healthcare system. And there is no way to go to the hospital because all hospital was converted as a residential home for COVID patients. So this is very important message to be taken. And I would like you to, and Shadha, to highlight on this as a practical issue. Second issue, you said, and also Dr. Nick said that there was a disruption and close down and postponing the NCDs in all, and Dr. Salman said in the primary health care and hospitals. So what about the self-care management? Is it an effective methodology apart from the telemedicine? I mean, how can we enhance this concept beyond COVID-19 era? Thank you so much. These 2 questions, practical questions.
Nick?
Thanks a lot. Well, I mean, I think there's been quite a lot of discussion about the delivery of services during COVID-19, and clearly in the immediate response to COVID-19, one wants to make sure that only those that are requiring essential health services are accessing it. And there have been a number of very good examples where people have used telemedicine and have communicated effectively remotely with patients. I know that, again, some in the United Kingdom, for example, a lot of GPs have managed to maintain services, so they say, effectively with people. Now, we'll only know in time how effective that has been because we will then start beginning to uncover the level of diagnosis that's been missed, the amount of treatment, whether or not people have been looked after well. I've also read that those that have significant experience in primary care have found it much easier to be able to move to counselling people and working remotely than those that have just started because they know their population bases. They have a better intuition and understanding when someone presents what they're presenting with. Much more difficult for somebody who's new in the game. It's similar with the way that we are communicating as a community remotely all the time. While we know each other well in our teams, in our groups, it's fine. As soon as new people come in, then it's much more tricky and you have to be much more prepared for the face-to-face engagement. So I think in terms of what the long-term impact is, we're going to have to see, but I think it wouldn't be unreasonable to say that actually there's going to be an increase in demand and unmet need as a result of this. Those would be some sort of initial thoughts. And the other issue, which I think is also a challenge, is prioritizing action at the primary care level and also at secondary and tertiary level. And again, that the guidance that I was illustrating and the operational guidance, which talks about non-communicable disease, does highlight the importance of prioritizing and goes through systematically on 2 or 3 pages in terms of what's required. We don't have time to go through each in turn. But again, it's quite a challenge to define what you mean as a priority case, because what's priority to one person, one individual, one community, one health service, one country, and where they are on the pandemic is different from another. So I don't think it's easy to make hard and fast rules.
I think I'll follow this, Nick, with Shadha. I really believe from the data which I've seen on primary care where we work, that everyone expected that with the closure of primary care, as you know, around the world, there were 3 types of strategies. We put it in paper, discussion paper recently. Some countries, they took a risk strategy and letting the primary care going on, seeing both COVID patient and non-COVID patient, and of course they regret it. Others, they took what's called risk avoidance by simply closing the primary care services totally, shut down, And the third strategy was a calculated risk strategy, like some of the European countries. I'm shut for face-to-face, but I'm here for virtual consultation and advice over the telephone. But from that, we noticed 2 phenomena. We noticed that people did not complain at all, especially with NCDs, let me call, I'm trying to use the terminology correctly, with the chronic diseases. And we noticed also that they didn't go to the accident and emergency department, to compensate for the lack of services. On the contrary, we've seen a sharp decline in the number of people attending A&E department, because normally 30% of the people attending A&E are for primary care, despite some countries that have a very strong primary care services. So decline in some places, some months, declined by 70%. So we believe that self-care became the dominant factor among those people. The Google medicine started to work, and these people became much more aware about their condition and searching for solution without a doctor. So what do you think, Shadha?
I'd have to say first, Prof, I do hope that they are actually seeking care. As we all know, the people with chronic disease, because of the symptoms, aren't actually presenting unless you tell them that, okay, you do have an issue and you're suffering from complications. They may not actually go seek the help of Google or whatever. So, but self-management, and I'll have to go back to what Prof. Khoja also mentioned, it is very crucial. I think one of the things that we had learned with the disruption of NCD services, and as you may know, Oman, we were very proud with how strong our PHC system was. Yeah. But then as the result of the disruption of services, we felt honestly very lost, because what we were trying to do, we were trying to limit that patient-physician physical interaction, but also our patients were starting to worry, or they didn't want to come into the health centers out of fear of being infected, but also our own healthcare workers were being reassigned to manage COVID. So what we did is we did conduct a rapid assessment ourselves, and as a result of these new interventions that were being introduced to primary care. And what we discovered was that there was an important, we really needed to have telemedicine clinics. So we are expanding these telemedicine clinics now to reach primary care and our NCD clinics. But when it comes to self-management, what we did discover is that 70% of our respondents, our diabetic respondents had been monitoring their diseases at home, while only 40% of those with hypertension were actually monitoring their diseases at home. So we really do feel, I think we're starting now this focus on self-management, and it's a very crucial component I think any NCD manager really needs to think of, because we need to start now educating our patients. I don't think we can rely on them searching for the answers on their own, but we really need to start these campaigns on the NCDs, on NCD self-management, when to seek care, and also the provision of home devices. We're working with pharmacies, private pharmacies now, trying to ensure that our patients get home devices devices at discount rates. So there's a lot of work that should be done until this pandemic is hopefully over soon. But there's a lot of work, I think, and we can focus on self-management as a crucial component of the management of NCDs. And now is the right time to do it, to focus on it.
Do you provide these home devices for free, or they have to pay for it?
For type 1 diabetics, we do provide glucometers for free, and not for BP apparatus, but we do have these, we have worked with private pharmacies in the past where discount cards were being given and patients were able to get the home devices at discount rates. So this had been an ongoing work at the past, but the pandemic kind of accelerated this work now.
Asmus, what do you think?
Yes, I think it's a very interesting question, and I fully agree. I mean, number one, every threat, including a pandemic, is an opportunity. And there's so many examples. If we think, for example, the figures that have been recently released in the UK of the willingness of smokers to quit, this is the best illustration, I think, on how we can harness this terrible pandemic for effective and public health action. So I'm very much a believer of this, and we're discussing that a lot here in EMRO as well. We also have a lot to build on, to draw a little bit on the point of Professor Tawfik earlier. We not only have an excellent World Health Report on primary healthcare more than ever, but we have, Astana conference documents. We have an EMRO-specific Salalah Declaration on Universal Health Coverage with a strong focus on primary healthcare. And we can further this agenda that's already undersigned by our countries in the Building Back Better initiative. I should also mention that, yes, this is a time to boost, digital health, telemedicine, and other tools that were mentioned. And we're all becoming more competent, and so are our clients, so to speak. At the same time, as a former family practitioner, as you have mentioned, I believe that the essence of clinical medicine and public health remains human interaction. And interaction in the sense that we build trust with our clients, our patients, with their families, with communities, and with our partners. And that, I believe, depends a lot on personal interaction still, and will in the future. And those of us who have already those relationships and their trust can quite easily switch to digital means. Those who come in new find it much more difficult. And I can imagine that a lot of our patients and even communities around the world still find it very difficult to continue chronic disease medication if they don't trust the practitioner who prescribed it. So I have certain concerns when it comes to digital medicine as well, and I think we have to very carefully disentangle what can be done digitally and what still needs to be done on an interpersonal level. Thank you.
Dr. Tawfik.
Thank you so much, Prof. Salman. This is really an excellent interaction from all of you. The other question is, listening to you, I would like to have in a short answer, what are the requirements to improving the healthcare delivery beyond COVID-19? Now we are almost the first wave is already gone. There is an era now between the first and the second wave. So what is the requirement of the healthcare system not to become as it was in the first wave? So what are the successful determinants for better health care system delivery in the coming era or in coming time?
Nick, did you hear that?
No, I'm just taking a pause and thinking about that, because first of all, clearly not all countries are at the same phase in terms of where they are. So, some are right in the midst of their very first response Others seem to have got somewhat under control and are now anxious about things. So I guess that this is a time, as Shadha was saying, to take stock between both those that are involved in the COVID-19 response, those that are involved in the broader health system and primary care, and those involved in NCDs, and to develop clearly a, I don't want to talk about a plan, but to identify what are the key actions that need to be, need to happen. Bearing in mind that we are where we are, there's no point in trying to expect that you're going to have something that's absolutely perfect in the next few months, but let's try and make sure we're a bit better so we understand issues around data collection, what we want and who's going to collect it and how that's going to be done in an integrated fashion. What are we going to do in terms of providing the service delivery? How are we going to deal with some of Asmus's challenges when he's talking about issues around telemedicine versus face-to-face? How are we going to try and make sure that those who now have got conditions that need to be followed up for diagnosis or treatment or for palliative care are accessing those at the moment without overwhelming the system? So I don't have an easy, answer to this, but I do think that this is a time when people need to sit around and to try and integrate their responses, taking into account the resources that are available, but also use this as an opportunity to say, all right, where we have got issues around large numbers of people that are using tobacco products or harmful use of alcohol, what are we doing in the way of maximizing initiatives that can have a very quick impact, like health taxes? How can we encourage ministries of finance and parliamentarians to ratchet up their events in this acute event? We're beginning to see governments that are talking about that. We're beginning to see governments talking about how they're going to start handling, some of the obesity issues. So let's strike while the iron is hot. Let's be working with the private sector to say, actually, filling up the products with the stuff that's causing obesity is not really very helpful at all. And let's start trying to make, some noise on that. I've heard one or two heads of state that have said they're going to do this. Well, let's see if they can turn this into action. So I think that, it requires focus. And again, it comes back to making sure that you've got that leadership right at the top. And that's drilling right down to the Ministry of Health and beyond to make sure that, population-based interventions quickly can be ratcheted up and that we can get some service delivery at the primary care level.
Thank you.
Shadha, I want to take this one a bit further. I know some colleagues from Oman are leading the discussion in our region on looking at health system resilience and how we can reshape health system in the future, because without any doubt, if you take any country, with the exception of maybe 4, South Korea, Taiwan, Singapore, Hong Kong, almost they are overstretched and prove to be with a lot of, I'm trying to be careful with my words, a lot of failures, disappointment, let me be free. And it is failure, the lack of PPE, the lack of protecting staff, the lack of zoning the hospital at the beginning, the lack of intensive care capacity, and so on, and so on, and so on. So would this health system look totally different in the year 2022?
Prof, you were actually disconnecting there, so could you repeat the question again? I'm so sorry. You were disconnecting, so I'm not sure if I had the question.
Reported failure in almost all health systems around the world, with the exception of handful. Would the system, because of the work which colleagues in Oman are doing and other across the region on health system resilience, will health systems by the year 2022 will look totally different than the health system today? You didn't hear me.
I'm so sorry. I'm losing you. I'm not sure why.
Any of the speaker heard me? Asmus, yeah.
I can very happily step in if you allow.
Yeah, carry on. I'll come back to Shadha later.
No, it's another excellent question, and you know, we have basically had daily sessions for half a year now in comparing the response and the successes and perhaps failures of regions and countries around the world, with a focus on our region, of course. And indeed, as you illustrate, we have a very broad and diverse response, and it's still ongoing, especially, of course, in the Americas, but also in Africa, our region, and even back in the countries where the pandemic started. I must say that I would be a little bit careful, number one, with judgment who's performing well and who's not, because I believe a lot depends on circumstance and capacity, and sometimes even sheer luck. I would argue that very geographically isolated countries such as New Zealand or others with small populations, or small countries with small populations, have been definitely in a much better position. Even the political system and the structure of the state itself plays a role. A federal state may be in a better position, not necessarily as we see in North America, but can be, like in Germany, than a more centralized state to you know, take effective measures. And then the pre-existing availability of technology, again, in countries such as Switzerland or Germany, have certainly given, I think, those responses a certain advantage when it came to you know, hospitalizing people. Those are, of course, only a few factors. There's many more, like identifying patients, testing patients, tracing patients, and so forth. But you know, circumstance has played a big role, as well as, of course, a political response. Will that have an effect on the future? Of course it will have. It is already having a big effect. I mean, you know, ministries of finance around the world are counting, you know, the cost, and discussing with ministries of health and, you know, with heads of state, how to better prepare and prevent and build back better. And I think we will see, you know, a significant change in, again, early warning system, early responses, hopefully, to future outbreaks, and also, hopefully, the health system's response. Just in short, thank you.
Thank you very much. Can you hear me now, Shadha?
I can hear you, yes.
There's a question from Dr. Naim Al-Qasir about when was the tipping point to recognize that NCD patient were not receiving the care they need?
Okay. The tipping point would have been when we realized, I think this was back in March, that we had a drop in OPD visits by 20 to 80% in our primary healthcare facilities. And most of course, our visits were patients with chronic diseases. So we realized we had an issue there. Also, as a result of the reorientation of services, we had introduced new interventions that would try to limit the patient-physician physical interaction. So, but really conducting the rapid assessment kind of informed us that yes, we had the interventions. We thought that our teams were able to provide counseling through phones, and that our patients, that some continuity of care were being provided. But I think that was the tipping point when we realized that only less than 40% of our patients were actually being contacted or had received that continuity of care. So we always, even very early on in this pandemic, and I have to say, I was personally very confused, and it was such a scary stage during the first few stages of the pandemic, because as an NCD manager, you didn't know how to proceed without having the provision of services. So I think really the rapid assessment kind of gave us that idea of what was happening.
And were there any, you mentioned about equipment sending to patients through pharmacies or supplied through pharmacies rather than sending it. But are there any reactive measures, i.e. in a proactive way, that you were, rather than waiting for the reluctant patient to come to you, that you go to them, you know, as it happened in some countries, not necessarily through doctors and nurses, but the use of community health workers, the volunteer, other means, you know, because in our calculation that any patient leaving home and suspected or infected with COVID, with the virus and got the disease COVID, actually the journey from home to the clinic or the journey from home to the A&E in a hospital may infect about 10 people. And this is one of the reasons for the transmission, that really people leave for any excuse. So any proactive measure from your side with those chronic diseases?
Yeah, and definitely. In terms of the guidelines that were produced, this was on the 16th of March. What was recommended was that our teams would go through the appointment lists and contact every single patient, so that those with controlled disease would be asked to stay at home and they would have appointments provided for them to collect their medications. We had some governorates where medications were actually being delivered to their homes as well, to the patients' homes, and they were provided with new appointments. But then our patients who were uncontrolled were encouraged to come and attend appointments. And obviously, every single patient would have been screened prior to entering the health facility. So there were some proactive measures. As I said, we also had some, actually all primary healthcare facilities had shared phone numbers, and where by WhatsApp messaging, patients would contact the facility and have medications provided, prepared, and appointments provided for them. So some measures were there that were, in a sense, proactive. But as I said, the assessment kind of told us that we had some gap in the provision of these proactive measures. So that's why I think the assessment really helped really clear things and really gave us that sense of direction to really go forward to telemedicine, try and use digital health as much as we can, as much as possible. And I think at this stage, we really have to rely on digital health as much as we can. But not only that, also that public-private partnership is something now we really need to focus on.
I mean, there is, I'll come back, before I go to Professor Khoja, there is a question from Dr. Ali Abu Thin asking about the positive effect of metformin on the patient who use it. I think I assume in relation to prevention of SARS-2 infection leading to COVID. Anybody got an opinion on this? I'll leave it an open. We have three people from primary care. I'm sitting here, but Asmus.
I'm smiling because I haven't seen very strong evidence of that yet. So many, so many theories have been circulated, and we have, of course, all the trials going on. And I would simply say it's too early to say at the moment. Let's wait for the trials.
Yeah, I think it's one of the recovery trial and as well as the solidarity trial. They are looking at the positive impact of metformin. Yes. Otherwise, all of us will take metformin. It's a very safe drug. So, Professor Khoja?
And cheap.
Yeah, cheap, very cheap. Yeah, Professor Khoja.
Thank you so much, Prof. Salman, and also my respected colleagues. There was so many areas we discussed here, but I would like to ask you if you can highlight what are the take-home messages you would like to be given to our healthcare decision makers regarding the NCDs during pandemics.
Dr. Nick?
So I think my first point would be that during a pandemic, which is where we are at the moment, an integrated response is crucial. It's really important that the NCD community, at whatever level, is talking and communicating with the COVID-19 community and vice versa. So that would be the first thing. The second thing is, I would say, is look and respond to your data all the time. So, you know, again, going back to Asmus's data, understand what's going on in your community, in your environment, and try and plan around that, because data is king in this situation. We've all got scarce resources, not just financial resources, but we've all got scarce human resources and service resources. We need to understand. So I think it would be about that. And then the third thing, I would remind people that many of the deaths from COVID-19 have been those people with who have used tobacco products, those people who have hypertension, who are obese, people with cardiovascular disease, with diabetes. These are critical people that are becoming unwell. And I would therefore say that actually it's really crucial to be starting to think about a comprehensive, coherent, joined up NCD response now and in the future. So those would be my three messages.
But I mean, Nick, you say that locking me at home, for example, for 4 months as a citizen in an X place, some people would argue that sitting at home, what I'm going to do, little exercise, of course, I will eat more, and I will add a little bit weight, and I start drinking more. And being bored, I'll have a couple of cigarettes a day. So that, again, the negative impact of the lockdown, unfortunately. At the same time, you know, most of the communities, they don't have the leisure of a garden or spaces around their houses. Majority of the people living in small flat or slums. And I mean, not everyone sitting in Beverly Hills in California, you know. So how do you balance between these two?
Well, the lockdown, if you like, has different impacts on different individuals and different communities in different countries. And so, you know, for the vast majority of people, I think it's been a time of huge uncertainty, fear and anxiety about health, about their employment. So I would say that if there have been any benefits from lockdown, it's been a very small proportion of the world and the population who have had access to your, as you described, some of your sort of West Coast environments. I think for the majority of people, it's pretty awful and pretty terrifying. So, and if there are behaviors, yes, there are a few people that have used this as an opportunity to improve their exercise, but most people have been trapped inside and found it, you know, very difficult in terms of tobacco use. Yes, some people have been encouraged to give up, but some people have been stressed and smoking more. Same with kind of alcohol use as well. So again, you know, when you think about those broader socioeconomic effects and the impact on health, it highlights the fact that health is so interconnected with many other issues and can't be seen in isolation. So when you talk about, you know, healthcare, you then think about health more broadly. Then you think about the broader socioeconomic and development situation of a country. And so I think it just reminds us how integrated and dependent we are on many other sectors for making people and keeping people safe, healthy, and for their well-being.
I'll come to the economic aspect. I'm glad you raised it, because there is an issue here. But I want to go back to Dr. Shadha. I hope you can hear us better now. Is that, yes, what Nick said is right, but we didn't see any activities from you on the media telling me as asthmatic, or indeed somebody who is diabetic, or somebody with other long-term condition. We didn't hear anything from you about what should I do, because all what the media was saturated basically with the number of cases, the number of deaths, increasing our fear, uncertainty. I see, and let me here teasing you. I mean, this is as a citizen sitting somewhere in Peru or in Qatar or in Baghdad and saying, you people, very large number, trained over the years, in a big crisis like this, your shine disappear. You were not there, you know. We didn't see your faces on television. We didn't hear anything positive from you about how I look after my health. What do you say to that?
Well, I think even people in Oman or citizens in Oman may say the same thing, because the media has been flooded with COVID-19 messages. But I have to say this, though, in the Ministry of Health and many healthcare providers in Oman as well, we had tailored our messages according to the situation. So we have been sending off messages to say to patients with asthma, patients with diabetes, encouraging people to maintain their physical activity and eating healthy and all that. But as I said, it is flooded nowadays with that COVID-19 messages. So, and our messages were mainly on the social media platforms of these healthcare providers and Ministry of Health. So I think that's an issue. But it really goes back down to the weaker whole of government approach when it comes to NCDs, when we compare it to this whole of government approach when it comes to COVID-19. And I think this is one thing that we may need to emphasize on at all levels, be it WHO or even country level, that we need that commitment from other sectors as well, that NCDs and communicable disease are now both an issue. And we need to have that whole of government approach. We don't control the media. So we really need to get our colleagues in the media, really on TV, interested. And the only thing that now is interesting them is that NCDs, one of the things that is interesting them is that people with NCDs could have a severe illness when they are infected with COVID. But that's not the only message we want to give across. We also want to give across that message to patients who are not infected with COVID, that you really need to self-manage your diseases and you need to look after yourselves. So this is one thing. But Prof, can I go back to one thing that Prof Khoja had asked as well? Is that okay? Because it is also a take-home message. And I think, as Nick had said over and over again, we really need to identify the gaps. We really need the data. We really need to know exactly what is happening, be it at the health system level, be it down at the service delivery level. I think every NCD manager really needs that data. Then we have really things that we should really be wary of. For example, the unmet need. Then we have this backlog of patients who we should be expecting or anticipating after the COVID-19 and how to deal with them as well. So we really need to have those lists of priorities, but also with the pandemic, patients who are infected with COVID may go on to have chronic kidney disease, may go on to have chronic lung diseases. So there's that also to plan within that health system. And one of the one word that has been repeated so often during this discussion was integration. So I think that word integration has to be at all levels of care. And that's the only way to go about it. We need to integrate the levels at the organizational level so that service is really continuous and we sense that continuity of care rather than focusing on PHC alone or hospitals alone. So that's just one thing and I wanted to mention as well.
Well, that's a very good point. And we have a question related to this, but slightly bigger in terms of the data on Asmus side. This is, let me ask you this question. I think it's an important question from Amal Hassanein, Dr. Hassanein. She's talking about, do we need to look at the trend of mortality or causes of death during the COVID period among NCD patients?
Yes, thank you very much. And if you allow me, I'll come back to this question in a minute whilst I go back also to Dr. Khoja's question a little bit, because I felt it was very, very important to also clarify the WHO point of view. And as both Nick and myself said at the outset, we have now a pretty clear set of recommendations to countries and ministries of health in what should be done for NCDs in COVID-19 with priority. Number one, the rapid assessments, as was mentioned. Number two, restoring and scaling up early diagnosis and care for those with NCDs. Number three, raising population awareness on the links education, public health promotion. And here, of course, we have churned out in the UN system, in WHO, a lot of very useful documents, including in our office, in our department in EMRO, on COVID and nutrition, COVID and smoking, COVID on alcohol, COVID and mental health, disease management. It's all readily available on the websites of Geneva and Cairo. And I urge you, if you haven't seen it yet, to look at those materials, which can be very nicely adapted in countries to raise that population awareness of the links. And then finally, the recommendation to identify opportunities to reduce risk factors, as we have said. And there indeed, smoking is a great example, as mentioned earlier. In terms of mortality trends and should we monitor them? Oh yes, I think it's critically important. And again, I think it came out as one of the recommendations from the survey at EMRO, that it's very important that we produce hard evidence, hence the surveys, but also further research that clearly demonstrate the immediate effect on the health of chronically ill patients and COVID. And that should indeed, I think, lead to hopefully even stronger preventive action. And if I can come back to Professor Khoja's one important point also, so what can actually governments do? For example, municipalities or housing or so. I believe this issue of lockdown that was mentioned by you also, Prof. Salman, is really educational, because what it means in consequence is that in the future, we may put more emphasis on healthy lifestyles in situations of epidemics or pandemics. For example, gyms in big apartment complexes, or adapted healthier malls, as was done in Oman and other places. There's so many things that other sectors can do, I think, to anticipate lockdowns of the future. And this is the time now to act. Thank you.
Well, thank you very much. So I'm glad you mentioned the WHO document and the many documents you have on the website. Some of us who are interested are read it, but I read it honestly on at least 2 occasions on the Technical Advisory Committee, WHO Technical Advisory Committee for COVID. That these documents are too long. And we are showered by so many documents from Royal Colleges, from CDC, from name it, from big institutions, from universities. When WHO will be able to produce a document which are readable, easy, not this with the jargons, we fed up with it, I'm teasing you here, we hear about it for years and nothing materialized. For God's sake, produce documents which are practical, everyone can read. What do you think, you and Nick? We have a couple of minutes.
If I can come back right away, because it's very close to my heart. And as you probably know from our dear friend, Dr. Al-Alwan, who has led the NCD agenda in our region and also globally for a while, he has really, I think, acknowledged this very much and has basically laid a tradition, certainly in my department, for the key documents not to be longer than 2 pages. Yeah. And what I'm showing you here is a 2-pager on the best buys of mental health, a 1-pager on the best buys of NCDs and so forth. So have a look at our website. Most of them are 2 pages.
Nick.
Salman.
Well,
one minute. We have 1 minute for you.
Well, I'm delighted to think that you were able to cope with 1 or 2 sides, because my understanding is these days that if you can't say it on a tweet, it's not worth saying at all, and no one pays any attention to anything else that's done on however many characters of a tweet. So if we can get something on 1 or 2 pages, that should provide us with ample opportunities. But why not take one of our documents that you think isn't great and summarize it into 1 side and throw it back in our face?
Yeah, I know you shared with me some of these documents when I was in your office before COVID, if you may remember. And I think it's really, that's how it should be. Very short, very crispy. I call it the Twitter style, something crispy people can read, can relate to it. I think at the end, I have only 30, maybe 40 seconds to thank you very much. Shadha, you are a star. Thank you very much. I learned a lot from this session. Asmus, my friend, thank you very much. And Nick, all the friend, I don't want to say all the friend. We go back many, many years, Nick and I. Again, great to see you on the screen, and thank you very much, all of you. Abu Abdullah, thank you very much for being with us always. You are a star. And Chido and my team at Imperial College, thank you very much. Next week, we are talking about the private sector during COVID. We have colleagues from Geneva and the chief executive of a hospital from Lebanon that will be moderated by Hala Abu Talib. And the week after that, and I think we touched on it through Shadha response, the role of the media during the pandemic. Again, we invited two media gurus with medical background from our region. Thank you very much indeed, and we will meet again next Wednesday. Thank you. Bye-bye for now.
Thank you so much. Have a great evening.
Bye-bye.
Thank you.